Hi, this is the respiratory video on the thoracic exam. This is my patient Allison. Allison, I'm Alicia. I just want to make sure that I have your permission to video you for my United States University class for my instructor to see.
Yes.
Okay, so to start off, obviously in a clinical setting, we would have a patient with their shirt off. So we could do a better inspection, but since this is for classroom purposes, we'll leave the shirt on at this point in time. First, we're going to just basically assess the chest for any abnormalities, any barrel chest, any concave chest. We're looking at the sternum. We're looking at that AP ratio to make sure that it is a 2-to-1. And with her, this is, a very regular size chest, but in a lot of COPD patients you see that barrel chest, or you may have a patient that comes in with a concave type chest. We're assessing their respiratory effort. We're seeing if they're having any, using any accessory muscles to breathe. In talking with them, we're kind of watching if they are dyspneic whenever they're talking, or if they're just dyspneic at rest. You can ask them about dyspnea and questions if they get short of breath with certain activities and things like that. Along with inspection, we're looking for any cyanosis in the lips. We're looking for any pale discoloration around the lips. We're also looking at the fingers. We're looking for clubbing in the nails. We're checking for capillary refill. So those are all signs of cyanosis and poor air movement. Then we're going to move on to palpation. First, we're kind of looking at the actual excursion of the chest. So you'd have the patient sit up. I'm going to have you sit on the edge here. And I'm just going to put my hands close together in this manner and have her take in a deep breath. And we're just looking for even expansion on both the posterior and anterior chest, that it's moving adequately, so we see both sides moving at the same time. While we're back here, we're also going to go ahead and check for tactile fremitus. We want to have the patient say 99. I'm going to turn this chair so I can get back to your back a little bit better, I think. Let's do it that way. 99. So in this, we're feeling for the vibration underneath. 99. When we're feeling for that vibration, we're going to have an increase in that when we have more dense inflamed tissue, and then we're going to have a decrease when we have more air or fluid in the lung spaces. We're going to have a decrease in that down here in these bases, maybe if they have like a pleural effusion of some sort, or maybe a pneumonia. We're also going to percuss the anterior and posterior. This, we're just listening for resonance. We don't want to be hearing any dull sounds. You obviously don't want to be over a rib when you're doing this. You're trying to get in between spaces. You're going from side to side. You want to be hearing the same type of sound. We can also do a diaphragmatic excursion when we're doing this. Have the patient take in a deep breath. Hold it. You're feeling here for the diaphragm, the change in the sound. Go ahead and breathe out. As I've marked that spot, then I'm going to continue to percuss, and then I'm going to measure. You can breathe. The amount there. A normal healthy person will have about 5 to 7 centimeters difference with that diaphragmatic excursion. The percussion we're going to do on the anterior and posterior. So I guess I can show how to do that on the anterior. We want to make sure that we're in between the ribs here. And then we can go over to the lateral sides as well. And next we're going to go ahead and do our auscultation. We're auscultating both the anterior and the posterior lungs. We want to do the apices. Taking some good deep breaths in and out for me. We're doing lateral, right and left. And then we're going to move to good deep breaths in. And we're going side to side because we want to be comparing both sides. We're listening for any wheezing, any crackles, any stridor. We're listening for good resonant air movement in all the fields. Because this is what's going to lead us when we hear advantageous sounds to do further testing as to where we think what might be going on. And then you can also do the bronchophony test. I'm going to have you do the 99 again while I'm listening with my stethoscope. We should hear this as a muffled tone. If it's heard very clear, that can mean that there is consolidation in the lungs. So I'm just going to have you say 99. 99. 99. 99. 99. 99. 99. 99. 99. 99. 99. 99, 99, 99, 99, 99, 99, and in all those fields, it's a muffled tone that I'm hearing, so I don't feel like there's any consolidation in there. And that is pretty much the thoracic exam. Thank you very much for your time, Allison.